We'll quickly move on to the next session titled Trauma from Chaos to Control, when every second counts. May I invite the chairpersons for this session, Dr. E.V. Gopi from Calicut, Dr. George Matthew, Chettipura, Dr. Afin Abdul Salim, Kollam, and the speakers, Dr. Santhosh Balakrishnan, Dr. R.C. Srikumar, Dr. Santhosh P.V., and Dr. Mir Chishti, please. Ladies and gentlemen, the free paper presentations have started in Hall B. Participants are requested to proceed there. The first speaker for this session, Dr. Santhosh Balakrishnan. May I request the chairpersons to kindly take over the session, please. Thank you. Yes, sir, please.
So, thank you, respected chairpersons, the organizing committee of the Kasicon 2023 and ASI Kerala for giving me this opportunity to begin this session on trauma with what is the most dramatic aspect of trauma, which is bleeding. So, trauma is essentially a situation where we would like to limit blood loss, but sadly it's also a situation where the effect of trauma results in a condition where the patient may end up losing more blood. Coagulopathy is in a form of DIC, and so there are two types that we know of, the fibrinolytic type, which we often encounter in trauma, and the thrombotic phenotype, which is seen often in septic patients where microvascular thrombosis causes organ dysfunction. So both are essentially the same in their basis, but the effects differ. So we all, coming on from the last talk where we talked of DVT and we know the importance of keeping the blood flowing, in trauma we know that we want to stop the blood flow, and the balance rests on these factors, a balance of the prothrombotic factors we see in black and the antithrombotic factors in red. Now in trauma, the cause of coagulopathy can be a depletion of coagulation factors, especially the common pathway fairly early on in the system during the trauma episode, followed by a state of poor activation of the coagulation factors, and finally there is overexpression of anticoagulation pathways, because of which the patient ends up going into coagulopathy. So let me just go into these situations one after the other. We all know trauma, including surgery, is a prothrombotic state, and predominantly because of expression of the activation of extrinsic pathway by the expression of the tissue factors, which sets off the extrinsic pathway. Also, inflammation and the inflammatory mediators result in a release of activation of the intrinsic pathway, and then thrombin itself, when it forms, accelerates the conversion of itself and also some of its catalytic coenzymes. Now, a little word about traumatic brain injury. Most of our trauma victims also have head injuries, at least in our condition, where road accidents contribute to a major bulk of this trauma. And so when there is damage to blood-brain barrier, there is a release of certain components from the brain which are clubbed into brain-derived cellular microvesicles, which accelerate coagulation and cause rapid consumption of coagulation factors. And almost you start seeing the effects of coagulopathy from this consumption between 3 to 6 hours of traumatic brain injury. And this is something to keep in mind. Even though the shock in trauma is seldom because of head trauma, it may contribute in some way to increasing bleeding in these patients. The next situation that happens is, after some time, after consumption, there is also poor activation of the coagulation factors. And the two main villains or contributions to the triad of death apart from coagulopathy, that acidosis and hypothermia, play major roles. The shock of the trauma and the chloride from respiration fluids results in acidosis, and therefore there is poor activation of factor 10 and 5. And this is required for conversion of prothrombin to thrombin. And this increases, there is also some increased fibrinolysis because of acidosis. Hypothermia also causes, predominantly caused by the poor perfusion and shock, but contributed to some extent by our own activities and the environment we treat them in, causes poor platelet activation, reduced binding of von Willebrand factor to glycoprotein 1b9 receptors in the platelets and the endothelium, which results in poor activation. There is poor factor 7a activation, thus reducing the extrinsic pathway as well, and also hypothermia induces fibrinolysis. Now, a lot of our patients these days are on oral anticoagulation for a variety of reasons, In fact, the most common joke I tell a lot of my students is you just have to walk past a cardiologist clinic and they'll put you on anticoagulation, you know. And so, yes, there may be benefits to anticoagulation, but it also carries a risk in a society such as ours where trauma is not uncommon. Shock by itself can derange PT and partial thromboplastin time, predominantly through its effects of acidosis, hypothermia, and our resuscitation efforts. The last nail in the coffin is often the overexpression of anticoagulation pathway. So the increased amount of adrenaline and vasopressin in the circulation is known to cause endothelial damage, and the increased glycocalyx degeneration causes release of heparin-like substances into the circulation, and also the damage to the endothelium caused by such actions also cause capillary leakage. Therefore, there is endotheliopathy mediated platelet dysfunction, and this is one way of poor coagulation activation, since platelet activation is one of the first steps in the coagulation pathway. Now, with endothelial cell damage, there is also activation of the tissue plasminogen activator. Also, tissue factor pathway inhibitors are released by endothelium and macrophages, and this effectively starts blocking the extrinsic pathway. And then as well, trauma causes release of thrombomodulin, which along with protein C will cause a thrombolytic pathway and also start causing thrombolysis and increase the risk of bleeding. So all this put together results in trauma-induced coagulopathy. So all this is fine to know, but how do we look after it? It's a major contributor to death. So diagnosing trauma-induced coagulopathy requires a significant amount of awareness and index of suspicion. Now, patients who present with low blood pressure are already in grade 3 hemorrhagic shock. Or people who are transient or non-responders. Transient responders respond transiently to volume, load or resuscitation and then go back into shock. And there is this group of non-responders who don't respond to any sort of resuscitation and need surgical intervention. Now, these are patients who may go into situations of massive transfusion protocol activation, wherein 3 units of PRBC in 1 hour or 10 units in 24 hours becomes required. In these situations, remember that there is a high possibility of these patients going into DIC. And conventional coagulation assays are helpful even today. An INR which is persistently greater than 1.5, a fibrinogen level dropping below 150 milligram percent, a platelet count falling below 100,000, and D-dimer levels growing over 500 milligrams percent or 0.5 microgram per ml should prompt suspicion. Now, in institutes which are privileged to have TEG or ROTEM, these can be used for goal-directed administration of the deficient components. So to prevent TIC, we avoid hypothermia. Now, this is a common scene in many of the trauma units. The patient is lying exposed, and we all know that the trauma units are mostly air-conditioned. So once you've examined the patient, remember to cover them up, preferably with warm blankets. Use warmed IV fluids, because IV fluids stocked in the resuscitation room are also cold. So if you can warm them to about 38 degrees, that would be most useful. We all know crystalloids are the basis of resuscitation, and it is still true. But beyond a certain amount, do not overuse crystalloids. Early use of PRBC is recommended to replace volume. And rather than delay hemostasis, we all know the treatment of bleeding is to stop the bleeding, not just filling up a cracked pot. So do not hesitate to take the patient to theatre to stop the bleeding. Now, a lot of trials showed that balanced resuscitation requires 1:1:1 RBC to plasma to platelet, but a 2:1:1 ratio is good enough. There is good evidence to show using tranexamic acid within the first 3 hours of trauma and then repeating it 8 hourly till the bleeding stops definitely has an advantage. Octaplex or prothrombin complex concentrates can be used, though its use is off license. And so we can stop this intervention when the patient has stopped bleeding actively and the following parameters are reached and the patient is still in the acute resuscitation phase. And once again, do not hesitate to stop the bleeding in theatre. Thank you very much for your kind attention and time. Thank you. These are my references.
Congratulations, Santhosh, for excellent talk about the coagulopathy. These are 2 important points in trauma. One is conception coagulopathy and hypothermia. You describe the science behind this hypothermia and conception coagulopathy. So very important topic. Now the topic open for discussion. One or two questions can be asked. Any doubt?
So, excuse me, if there is no question from the chair, I will just ask, now the threatening for the surgeons after trauma, we will be transfusing a lot, we will be correcting the hypovolemic shock, then the patient will be going into DIC. So, apart from acidosis and hypothermia, what is the role of hypocalcemia leading to DIC?
I mean, hypocalcemia should be considered when we are transfusing the patient massively. It's usually part of the massive transfusion protocols in most hospitals. So as we go into the MTP protocols, then we should consider supplementing calcium. Though there is no definite formula or amount recommended, but definitely if calcium replacement should be part of massive transfusion protocols.
Most of the coagulopathies, usually results are normal. All investigation will be within normal limits.
Yes.
How will you manage that condition?
Well, as I said, though there are markers that we can use, and nowadays TEG and ROTEM can give good inputs to resuscitation. I think if a patient is showing signs of bleeding in trauma despite our attempts, then we should assume that they have coagulopathy and treat accordingly by supplementing factors. Because it is not always easy to prove it, as you rightly said, sir. Now, keeping them warm is very important, and preventing hypothermia, that's very important.
Yes, then we'll go to the next
Thank you very much.
speaker.